on to our next patient.
All right.
And you did this HFP, right?
Yeah, I did. I saw him this morning. So Mr. S is a 73-year-old veteran with a history of coronary artery disease, status post-CABG ×3 in 2014, CHF with an ejection fraction of 30%, COPD on 2 liters O2, obstructive sleep apnea for which he's non-compliant with CPAP, diabetes with his last A1C of 12, chronic low back pain, hypertension, hyperlipidemia, and prostate cancer. So he was sent in from his primary care appointment after presenting with 3 days of increasing shortness of breath. He was in his usual state of health at home until 3 days ago when he had increased exertional shortness of breath and a decreased exercise tolerance. So he was able to walk to get his mail at the end of the driveway, but is now short of breath when moving around the house. He has increased his albuterol use to 6 times a day with minimal relief. He's noticed a worsening of his chronic cough, while normally productive of a white phlegm, but it's now thick and yellow like a clam. He has no exertional chest pain, but has had some pain with coughing and deep breaths. He denies any increase in lower extremity edema, weight gain, or postnasal drip. He recently visited his grandson in Virginia who had a cold. He has not had any chills, doesn't know if he had a fever, denies any difficulty swallowing, GERD, bright red blood per rectum, melena, constipation, or diarrhea. He gets up 3 times a night to urinate and has some hesitation in a weak stream, denies any hematuria or dysuria. He's also had no hemoptysis. His vital signs at the primary care visit showed an O2 sat of 85% on 2 liters, so he was sent to the emergency room. And in the ER, he was afebrile with a heart rate of 118, respiratory rate of 22, and a blood pressure of 160 over 100. His lab showed a white count of 16.2, chest x-ray showed hyperexpanded lung fields with no infiltrator effusion, and his EKG showed tachycardia but no acute changes. He was treated with Duanebs, IV Solumedrol, doxycycline, and ceftriaxone, and transferred to the floor. Mr. S is a 73-year-old veteran with a history of COPD, CHF, and poorly controlled diabetes who comes in with 3 days of increased shortness of breath and cough in the context of recent contact with a sick grandchild. So on exam, he's afebrile, hypoxic to 85%, tachypnic, tachycardic, and hypertensive. Data is significant for a white count of 16, a low BNP, and a chest x-ray without evidence of any infiltrator failure. So our differential diagnosis includes COPD exacerbation, CHF exacerbation, bronchitis, or early pneumonia.
Great. Great job, Dan. Let's go see the patient.
Okay.